Okay, so for this case study, I'm here with my volunteer patient, Alana. My case study is an 18-year-old male high school pitcher presents to the AT room complaining of right shoulder pain. He had a chronic onset of symptoms 3 weeks ago after practice. Over the last 3 weeks, his intensity of pain has steadily increased. The patient notes a decrease in symptoms once he starts throwing. There's pain he reports pain over the posterior lateral aspect of his right shoulder. Ice and NSAIDs to provide relief have worked thus far. Social history, patient is right-hand dominant, lives at home with his parents, has a part-time job, pitches 5 days a week at practice, and starts one game every 5 days. So let's get started. So for history questions for my patient, I want to ask about, pain patterns. Does it bother you in the morning when you wake up? Does it bother you at night when you go to sleep? Is it waking you up in the middle of the night while you're sleeping? Have you changed anything about your practice schedule, practice patterns, or your throwing motion itself? Have you changed your throwing mechanics? The ball you throw with? Have you changed the types of throws you're pitching? Are you started throwing more junk curves, balls, sliders, or are you sticking more with the fastballs? Do you have a history of shoulder injuries? If so, what, when, and what referrals did you get to go? What other doctors did you see? Did you have surgery? Did you see anyone about it? Chiropractor? Those kinds of things. Other important questions you want to ask are about his job. What are his tasks at his job? Is he doing a lot of stocking shelves where he's overhead kind of all day long? Is he working for anyone else? Does he have at-home chores? Is he helping out on like a farm at home? Other questions about baseball are, is he playing a fall ball, travel ball, all-stars? Does he have a pitching coach, off-season training? Like, what did that kind of look like? Those are the big history questions. Then my observation is next, but that starts as soon as they enter the AT room. You want to look about how they enter the room. Are they leaning one way, one shoulder lower than the other? Are they, holding one arm? Are they holding one shoulder? Is one arm hanging at their side lower than the other? How do they get on the table? Are they using both hands and jumping up, or are they kind of gingerly like sitting down? How do they take their shirt off during an inspection? So are they, dropping one arm or just using one to get it off? You want to look at all those things. Sitting here, you want to look, start with, you can do posture. Are they sitting nice and tall? Do they have anterior rotated shoulders? Are their shoulders level? So using their collarbone, AC and GH joints is kind of a level. Are they out of whack one way or the other? Signs of inflammation, redness, warmth, obvious deformity, looking for all those types of things. No sign of any of that on initial inspection. It's really important with the shoulder that you are taking both an anterior and posterior view. So I'll come around to the back. And this would be a good time to continue my postural assessment. So now that we're in the back, I'm going to have Alana do her active range of motion. So I'm going to have her actively flex both of her shoulders and go all the way up overhead. And then good. So with this, you want to keep an eye on your scaps. Is there any scapular dyskinesis going on, unnatural rhythm? Also assessing the quality and quantity of her active range of motion. So she had full active range of motion there, full 180 degrees. I'll then have her bring her arm straight out in front of her at 90 degrees. And then I'll have her abduct all the way out. That's horizontal abduction. Good, full range of motion there. And then I'll have you come back to the hands at your side. Can I have you do just regular abduction out to the side? Go all the way up over your head. Good. with all of these motions, you want to keep an eye on your scapula. They all seem to be good. Good adduction all the way down to your sides. Full range of motion there. So those all look good. Coming back to the anterior aspect, I'm gonna now start getting my hands on. So I'm gonna ask Alana, are you okay if I touch you? Especially with this, where we're in the chest and face, so we really want to make sure the patient is comfortable with what we're gonna be doing. So I'm gonna start here at your SC joint. So 2 thumbs there. Get the suprasternal notch. Palpate the clavicle, working laterally. Assessing for any gaps or bridging, coming out to the AC joint, acromion, looking for any spots that are tended to palpation, coming down to the coracoid process. With this, again, you can assess for changes in temperature. Does it feel warm? Does it feel cold? If it was cold, that would be an indication that there's a loss of neurovascular supply. So now that we're at the coracoid process, coming over to the head of the humerus, assessing lesser trochanter, bicipital groove, and greater trochanter. Looking for areas of tenderness, working down the back of the arms, triceps, deltoids, down to the deltoid tuberosity, and I'm continuing down the shaft of the humerus, down to the elbow, looking for any signs of pain. Then coming laterally and posteriorly, I want to just roll our shoulders back a little bit. Triceps, like I said earlier, using the acromion over the shoulder, palpating the spine of the scap, then down the medial border to the inferior angle, and then back up the lateral border, and then a nice big old press in the middle of the scap, just to, again, keeping an eye out for tender spots or any gapping, bridging, anything like that. Okay. I'm gonna edit this out for a second. I'm just gonna edit this chunk out.
Yeah. Now I do your range of motion, passive range of motion, active, manual muscle testing.
Yeah.
But you're on track.
Do I want to do range of motion? Yeah, I might as well. Okay. Okay, so we're gonna do some goniometry next. Starting with flexion, so taking the fulcrum of the goniometer and placing it over the head of the humerus. Stationary arm pointed down to the ground. Alana's resting. Actually, can I have you stand up?
Sure.
This is probably easier to do in standing, so the arm can hang all the way down to its side. So I'll have Alana actively flex her arm, realign the goniometer with my landmarks, and then she's got a full 180 degrees of extension. I'll have her do the same thing going backwards into extension, so maybe rotate this way so they can see. So come back into extension. Again, head over the head of the humerus, stationary arm pointing down to the floor, and then movement arm down the humerus. Good. She's got normal range of motion, 60 degrees of extension. And then I will have her do abduction. So now using the AC joint and the acromion as your landmark for the fulcrum, I'll have her abduct her arm all the way. Good, realign. And you can see that she's got a full 180 degrees of abduction. Come down. We usually just assess adduction by seeing that she can bring her arms down and touch her sides, which she is clearly doing. And then I'll now have you lay down and we'll move into external and internal rotation. So you can lay down on your back.
My back?
Yes, on your back. With your head down here, please. And I'll lower you guys so you can. Okay, we're just gonna. That's gonna be a cut.
That's a brutal sound.
That was a brutal sound. Okay. Okay, so now that we have Alana here laying on her back, we're going to measure internal and external rotation. So fulcrum is going to go, you can actually scoot. Actually, just kidding. Fulcrum is going to go over her olecranon fossa. Stationary arm is perpendicular to the floor. And I'm going to have her just gently go into internal rotation, so going forward this way. And I'll let her drop into that. And then I want to line these all up again. And then the movement arm is going down her ulna. And she's got 90 degrees of internal rotation, which is totally normal. And then setting back up in this kind of resting position, and I'm going to have her come back into external rotation. Do the same setup with the pelvis. And she's going to have a full 90 degrees of external rotation there. Yeah, so that's it for goniometry. I'm going to now have, I'm gonna have her come back into a short sit position, and we're gonna start some of our special tests. Okay, so for my first special test, we're gonna have Alana do what's called a Valsalva maneuver, which is checking for disc herniation. So I'm gonna have her sit nice and tall. And I'm gonna instruct her to make a fist with her hand, and then she's going to blow into her fist without letting any air out, kind of like she's either blowing up a balloon or having a bowel movement. And we'll do that for 2-3 seconds, and then I'll have her relax. I'm looking for any lightheadedness, numbness, and tingling for possible disc herniation. So we'll have you do that. Okay, good. Any pain, numbness, tingling with that? Okay, wonderful.
It's okay, I wasn't supposed to blow her hair out.
Okay. So next we're gonna do what's called a military brace position, which is checking for thoracic outlet syndrome. So I'm gonna place the patient into cervical extension, and then I'm gonna bring her arm into external rotation and extension, looking for numbness and tingling, or a change in temperature or a loss of pulse, radial pulse here in her arm. And she's good. So that's checking for thoracic outlet syndrome. Next, we're gonna do with the sulcus sign. So Alana, our real life person, has a positive sulcus sign, so you will see a positive sulcus sign here. So there you go. That's checking for inferior instability of the glenohumeral joint. Next, we're going to do crossover impingement. So I'm going to have her cross over, looking for pain. I'm going to push here, so looking for pain there. You can do Jurgensen's, which is external rotation and supination, looking for bicep tendinosis, tendinitis. So I'll have you push into my hand. Good. Looking for pain or any popping or clicking here in the bicipital groove. Okay. Sulcus. Okay, I need to do a Brian drop arm. So next, I'm gonna check for a slap lesion with the O'Brien's test. So I'm gonna have her instruct the patient to. I just realized that this whole time I've been using your left shoulder,
My right shoulder?
but the patient's right shoulder is injured.
I've been using my right shoulder the whole time. You're good. Reset. So you have to do posterior, Job's.
But I'm doing those when you're lying down. So for sitting up, I have
Do you have any like
O'Brien, drop arm, empty can.
you should low-key do a shift and load while you're here. That.
Okay.
You could if you wanted to.
Okay, so next up we're gonna do O'Brien's test, which is checking for a slap lesion of the labrum. So I'm gonna instruct the patient to, we're gonna use this arm, crossing over, thumb down to the floor. I'm gonna stabilize and push. There should be pain with that if we had a positive test. I'm now gonna instruct the patient to thumbs up towards the sky, repeat the same pressing. This should be no symptoms. So if it's pain here, no pain here, that's a positive O'Brien's test, so indicative of a slap lesion. Next, we're gonna do a drop arm test, which is another impingement test. So I'm gonna instruct the patient to actively bring her arm up, and then she's going to slowly drop her arm down to her side. We're looking for control and smooth movement there. And then we're gonna do a load and shift. So for this one, we're looking for instability in the shoulder. So we're gonna load the shoulder, and then we're going to anterior shift. Sorry about that. And then load and posterior shift, looking for instability in the ligaments. Now I'm going to have the patient lie down on her back. We're gonna do a posterior apprehension test. So I'm gonna have the patient cross over their face like this, and I'm going to axial load the humerus, looking for pain and laxity with this. Next, I'm going to do anterior or Job's relocation and anterior apprehension and Job's relocation. So here, putting it into external rotation, looking for the head of the humerus to pop up out of the glenohumeral joint. If I saw that, I could do Job's relocation to put it back into place. This should stop the pain. And then surprise, we would see it pop out again if there was anterior instability of the glenohumeral joint. Now I'm going to have the patient roll over to her back.
On my stomach?
On your stomach. Can you go to
This is the arm you want, right? You can move the stand over this way.
wait, hold up. This one is this, right? You go here, and you just try to lift this off.
Yeah, get real lift off.
Resistance.
You could also do it seated if you wanted to too.
With resistance though, right?
Just see if they can do it. If they can't do it at all first, it's like a super weak muscle.
Yeah.
So if they can't do it at all, stop the test there. If they can do it, you can give them a little resistance, but it's not really like.
Yeah. Okay. Bye, Caitlin.
You guys all good with everything?
Yeah.
Okay.
Thanks for your help today.
I have it on Tuesday too, if you guys need
Okay.
anything.
I don't know if I'll be here this Tuesday, but I know are you going to be doing it like the next Tuesday?
I do it every Tuesday and every Thursday and every Sunday.
Okay, well, I won't be here this Tuesday because I know I have to go to clinical, but
That's fine.
I will definitely be here next Sunday and the following Tuesday.
Honestly, might be
Ultimately.
on Tuesday. So what time during on Tuesday?
I do Tuesdays and Thursdays are 1 to 2,
Okay.
and Sundays are 2 to 4. Unless if I change it, then I bring it an email to let you guys
Okay.
know.
All right.
Okay.
Thank you.
Thank
Yep.
you. Okay, so for my final special test, we are going to do Gerber's liftoff, which is a specific manual muscle test of your subscap. Teres, or just teres minor.
Subscap.
Okay, so we're gonna do Gerber's liftoff as my final special test, which is a specific manual muscle test for the subscap, which is a muscle of your rotator cuff. So the patient is laying on their stomach with the back of their afflicted arm kind of coming back onto the small of their back. And I'm going to instruct Alana to try and raise her hand up off her back and maybe just kind of give me a high five. That's about all you can expect from patients. If they can get it off, that is a successful, that's a negative test. If they were not able to get their hand off their back, or they had severe pain with getting their hand off their back, that would be a positive Gerber's liftoff test of the subscap. So based off the findings of my results from this eval, my differential diagnosis is a rotator cuff impingement, rotator cuff tendonitis, or posterior instability of the glenohumeral joint.
There you go.
Sweet. Cheers. Cheers. Cheers.